Good morning, everyone. This webinar is being recorded this morning so that colleagues can watch it later on. It's the 21st of July, and thanks for joining me this morning. So I've got quite a few updates for you this morning. Some of them are clinical. I just wanted to remind colleagues about what I said maybe last week about minor surgery and the part of the DES. So we can now start, according to the standard operating procedures, doing minor surgery and joint injections in primary care. And as you may know, income protection doesn't qualify for July onwards for this part of the service. So we should really start these back in primary care. I think the key things here are we need to undertake an individual risk analysis on a case-by-case basis. So obviously we must make sure that we're not injecting somebody who's got COVID or recent COVID interaction. And we should use clinical judgment and decision making, determining their age, health, clinical risk, and comorbidities. But really, what we're saying is that if anyone's got sort of osteoarthritis, shoulder pain, lateral hip pain, carpal tunnel syndrome, all those types of things, and they're having high levels of pain and disability, or it's affecting their activities of daily living, and all the other first line measures have failed, then it's quite reasonable to give an injection in primary care. The key things I also wanted to remind you today was about the QOF changes in 2020 and 2021, which are quite important for colleagues here today. And that is just to remind everyone that we are being looked at to provide the winter flu programme. So practices should think about how we're going to provide that, whether we're going to be doing that in individual practices or with support through our PCNs. We're being monitored this year on early cancer diagnoses, providing learning disability health checks, and maintaining accurate disease registers, our cervical screening indicators, uncontrolled long-term condition parameters, and patients with a history of missing reviews. And what we're being told is from, as I said previously, from the 1st of July, we should now be doing new patient reviews, routine medication reviews, over 75s checks, frailty reviews, shingles vaccinations, flu jabs from September, October onwards. And we're also now being asked from August, certainly, to recommence LCSs in the borough. And I know that NCL are looking at those. We're also being asked to resume normal complaints management activities and sort of any other clinical care that we haven't been doing. The things that are suspended until the 30th of September are the friends and family test and the requirements for patients to consent in certain circumstances to transfer a patient to electronic repeat dispensing. The next part of the webinar this morning I wanted to cover was clinical aspects of COVID. So there's been a big discussion about when a chest X-ray should be done in COVID or post-COVID patients. Now, really, what we know is that most patients with COVID-19 infection have mild illness and don't really develop pneumonia. But actually, 63% of COVID patients can have a normal chest X-ray, but actually could have a pneumonia. And that actually is quite a significant fact. So what do we see when the radiologists see the X-ray? What are they looking for? Well, actually, most of them have this sort of ground glass appearance, or that horizontal linear opacity seen, and they can also get consolidation. Now, actually, the ground glass appearance is common in early COVID pneumonia, but then it also involves bilaterally the part of the lungs, and actually that can happen in about 70% of COVID pneumonia patients, and it's generally only unilateral in 25% of those cases. But what we're also seeing, and things to be aware of in primary care, is if you've got a young person, we're now seeing is pneumothorax or pleural effusions in about 3% of post-COVID patients. So that's really an interesting fact for us to be aware of. And actually, someone who may have had COVID a while back, several weeks back, who presents with sort of pain or breathlessness could have a pneumothorax or pleural effusion, so about 3%. So that's reasonably significant and something to be aware of. The next thing I wanted to tell you about was a really interesting study that I thought would be relevant to us, and that's about the 6-cluster study of symptoms and a prediction tool. So, and this has been particularly done across Europe, and there was analysis of data obtained from a symptom tracker app in Europe that has been shown that there are 6 distinctive types of COVID-19, and they're distinguished by a cluster of symptoms. So what it said actually, and this is actually being looked at by King's College in London, in that the clusters are, the first cluster was a flu-like illness with no fever, but people did have a headache, loss of smell, muscle pain, cough, sore throat, chest pain, but again, no fever. The next category was flu symptoms with a fever, and again, all those sort of loss of smell, cough. They also thought that actually a lot of people have gastrointestinal symptoms in COVID, so they can have no cough, no fever, but they have a GI illness, sort of diarrhea or vomiting, and they do also have the loss of taste and smell, and predominantly diarrhea or vomiting. The next sort of category was where people are quite unwell, so we call mildly unwell, where they have fatigue, headache, loss of smell, fever. And then it goes on to confusion, headache, loss of smell, fever. And then really level 3, what they thought was those presenting with abdominal pain, which we've historically learnt about in COVID, and they then tend to have quite significant respiratory disease. So that's actually slightly reassuring for us, because we've been seeing people with abdominal pain here, and we're worried that actually, they could have COVID. But what this study showed is that those generally with abdominal pain have quite significant respiratory symptoms, and they're not the mild patients. And so those with abdominal pain tend to have significant respiratory, headache, loss of smell, loss of appetite, fever, bad cough, hoarseness, often very bad chest pain. They're quite fatigued. They can start to become confused. They're very breathless. So that's what they said for that cluster of groups. They generally, in this study, found that the majority of patients actually have the kind of sort of fatigue, headache, loss of smell, cough, and fever, and that was present in about 40 to 50% of patients, so quite significant. And actually, only sort of 8% ended up with the severe symptoms, and out of the 8%, 45% of those ended up in hospital. And what it also concluded, and this looked at thousands and thousands of patients across Europe, is that those patients who ended up in hospital generally were all over the age of 80 or had significant comorbidities. And it also said is that if you provide patients who are quite unwell support by day 5 or around day 5, actually they're likely to get rapidly better. So actually what it's suggesting is that these patients should be maybe referred in on day 5 if they're starting to deteriorate. And we've also talked previously about this cytokine storm that tends to happen at day 8, day 10. But what they're saying is if you pick them up at day 5, they've actually got a better chance of survival. Now, why have I talked about that when you're probably thinking, well, COVID's quite quiet at the moment. We're not seeing huge amounts of it. But actually, as you know, we are seeing significant peaks across other countries, America, other parts of Europe. And the prediction now is coming that we're likely to see peak probably either early winter or towards December period, despite what our Prime Minister says. Public health experts are talking right now about a second peak, and these are things that we really need to be aware of. I'm going to stop there with the clinical aspects of my update this morning. I just wanted to cover one of the questions that came up last week about cremation forms, which I thought was really relevant, actually. I did answer it in the chat bar, but I just thought I'd just talk us through it. The question came about was whether we need to see sort of somebody if we are filling in a cremation form 4. Now, during COVID on the Coronavirus Act, we can now complete a crem 4, as you know, even if we didn't attend to the deceased during their illness before or after death, as long as somebody has seen them in the last 28 days in our practice. And that could be either in person or video consultation. Therefore, if somebody's been seen in 28 days, examination of the body is not required to complete the crem 4, even if they were seen by another medical practitioner. But what the MDU is suggesting is that the person then completing the crem 4 should be a partner in the practice, so they should be on the CQC register at that practice. So it shouldn't be somebody who comes and goes or a locum in case there is an issue with the cremation form 4. That's what the MDU suggests, but the guidance doesn't specifically say that. And then on the Creme 4 form, where it says were you the usual doctor, you can just say cross that and write down who the doctor was. And I've put the text in the chat bar. Martin's asked about the cluster paper. Yes, absolutely. I can provide a link to that at the end of the webinar. I think it's a really good read to read the whole of the paper, so I'll happily provide that in the chat bar in a few minutes. I'm going to pause there because it's 10 minutes already. It goes quickly. Are there any questions from colleagues? Anyone want to ask me anything at all? If you do feel like you need to ask something, just pop it in the chat bar and I'll answer them before Friday. Otherwise, have a fantastic week and I'll see everyone on Friday. Thanks very much, everyone. Have a good day.
Thank you. Thank you. Thank you.
Bye,
Thank you. Have a good day, mate.